important in trauma, when we're talking about trauma-informed care, the essential question is, what has happened to you, not what is wrong.
Every student carries a story, sometimes one shaped by trauma. Today, we'll explore how supported educators can create classrooms that heal and help students thrive. Welcome to the Lippincott Spark, Illuminating Nursing Education podcast. I'm Dr. Kelly Drees. Join us as we ignite your passion for nursing education and leadership. We'll explore the latest trends, hear from expert nurses, and provide tools to keep you inspired. Let's dive into today's episode and continue your professional development journey together. A nursing student freezes during a clinical simulation, not because they didn't study, but because their nervous system is in survival mode. This isn't rare, it's real. It's reshaping how we teach. Welcome to Trauma-Informed Teaching, empowering educators to transform student outcomes. Today, we're exploring how trauma, often unspoken and unseen, can quietly chip away at a student's ability to learn, connect, and thrive. I'm thrilled to be joined by Dr. Melanie Gray, clinical professor of nursing at Marquette University and a national leader in trauma-informed education. With over 20 years of experience in both clinical care and higher education, she's helped transform nursing programs into more compassionate, inclusive, and resilient learning environments. Dr. Gray, welcome. I'm excited to talk with you about how we can begin to truly see our students, not just as learners, right? But also as whole people with stories that reshape how they show up in our classrooms. So welcome.
Thank you so much, Dr. Drees, for that wonderful introduction. I'm so excited to be here with you and to be part of this very important conversation.
I've heard you speak before, and I am really interested in hearing a little bit more about hidden stories of students and what they carry and how educators learn to pause and truly see learners' unique experiences.
Yeah, I really appreciate that. It's so important. And I think at the core of being able to see a student and really connect with them is being committed to being relational and being human while still being an educator. I think that in my experience, educators feel that they have to have a posture, with the students. And that posture of being the educator, and having this, sharp desire to push expectations actually create stress for the student. We have to remember as educators that we have stories too. And that they always say facts tell, but stories sell. What are we trying to sell that student on? That you can succeed, you can do it, and still meet the expectations. So it's important that we posture ourselves as being human and addition and relatable while still being an educator. How do I do that? I was first generation college. I'm an African American woman. I had to work my way through. I had absolutely no help from anyone. I had no one to tell me how to do anything. I worked every weekend throughout my college career, my undergrad, and no partying for me. So I tell the students that this is my story. I grew up in the worst zip code area in Wisconsin, 53206, but I was able to journey through it. I haven't forgotten how hard it can be, and you can do it too. I think being transparent to that level helps students say, oh, okay, I can do it. And if she was willing to share that she grew up over there, then maybe I can talk to her.
There's these multidimensional variables that impact a student's ability to persist, right? All of these things that they're dealing with, childcare and transportation maybe needs, lack of support or financial issues. They're working 3 jobs. They have children to take care of and maybe even trauma, childhood experiences or systemic discrimination or the pandemic related stress. There's so many stressors that students are feeling today. So what does that trauma actually look like in our classroom? And can you share maybe a moment when you realized trauma-informed teaching wasn't just helpful, but essential?
Yes, it looks different in every student. So young people, I hear them often say, "Do you see me?" That's something I want to be seen. And so, first of all, when you see a student falling asleep, when you see them not having eye contact, when they won't raise their hand, and everyone isn't talkative, right? So as you can, pull those students aside. I would try to have a 10-minute meeting with every student, even if I was in theory. I'd say, "Hey, I want to see all of you in this next week for 10 minutes so that I try to get to know them." When I am in clinical, I make sure that I'm very intentional about making that student know that I've seen them, I've been with them, I see their plan, I see their growth. And so, or else they'll withdraw. So first you have to be observant. I think as educators, we have to be intentional about making that connection with the student. And the more students know that you know, the more they'll tell you. Now, that could be like a 2x sword, but I think that it supports the student in feeling safe, because nursing school doesn't always feel like a safe place for students, right? And we can't forget that our students are trying to navigate the same society, the same context of life that we are. And so if we know that everyone's stressed about $6 eggs, I don't know how much they are in your neighborhood, but the cost of inflation, our students are too, and they're having to navigate all that. If we're stressed by the news, they are too. So I think being intentional about what you are seeing, follow your gut, and then be willing to have a conversation about it.
I've seen firsthand how you have really provided a psychologically safe classroom for your students and really seeing them, because we know that this trauma affects cognitive function, right? It impairs memory and attention and executive functioning, and they need those skills for clinical reasoning and academic success. So now that we've kind of explored what trauma looks like in the classroom, whether they're falling asleep, or maybe they're a little bit distant, or maybe they have a little bit of a crassness to some of the responses that they have presented, let's talk about a little bit what we can do about it as educators. What is one small change an educator can make tomorrow that would immediately make their classroom more trauma informed?
Well, I think doing a check-in. I think before every theory or every clinical, have a pre-brief. If I'm in a theory class, okay, you guys have had 3 exams this week, or you have 3 coming up. Tell me how you're preparing for that. How are you feeling? I heard that this situation happened to a student. I want to give you the school's position on that, because students are going to talk, and they, it goes like, wow, there's misinformation in every nursing program, right? So I think by having a pre-brief, let's talk about the misinformation. Let's talk, tell them this is what I heard in the hallway, y'all. Tell me what's going on, have that pre-brief with them. And when it comes to clinical, when you feel the pulse of the unit, if you know they've had a lot of deaths, if you know they have a lot of new grads on the floor, then have that conversation and then make the adjustment. Sometimes I pull students back and maybe I'll buddy them up. Even if they're juniors and seniors, I'd rather take fewer students and take the stress off of the unit than put my students in an environment that is not safe. So you got to have that pre-brief, explain to them what you are doing, and then have the debrief. For theory, we've gone through this lecture. This is what I hope that you got from it, what you should have. And go through the book. Once you've done the lecture, show them review how to study the book, how to capture the information and so reduce their stress. Help them understand how the test plan is made. You're a junior. We can't just have factual knowledge questions. This is what you can expect to see. This is how you need to study. Show them. They don't know what you know. And nursing school is new for them. And if they never had a parent or someone to tell them what college is like, they're treading water. So they really need our help to survive and do this. So that's important. That debrief is important for theory, I think. And we know we always have post-conference. That's part of clinical. But how we do it, talking about the feelings. How did it make you feel? One of the observations I've made and in my discussion with many educators is that students now do not like to ask questions. They don't want to. So I asked, why will you not ask a question? They won't ask it in public. Because they don't want to look stupid. And students think we're always judging them. So that's the other reason why trying to find individual times with them and seeing them can open that door.
Having that psychological safety that you just, mentioned, to making sure that students feel comfortable sharing concerns, sharing their mistakes without fear of embarrassment, fear of, shame or ridicule or retribution, and being able to create that safe learning environment. So how do you balance that academic accountability with emotional safety, especially when students are really struggling? Because nursing it's the most trusted profession, but it also comes with a lot of responsibility. So how do you balance that?
I believe that we have to be honest and realize a couple things. Tell students, you have to make this level. And this is why. The school has an accountability to our accreditors. Accreditors and our State Board of Nursing have an expectation of us. There is a public trust we've committed to maintaining for safe care. So when we don't meet the expectation, it puts the program and the care in jeopardy. Explain it to them. Doesn't mean you don't see the student. And you have to tell them, so this is hard. I can see that this is hard for you right now. Now, let's problem solve and see what we can do together to create a solution. Do they need accommodations? Do they need to drop their load down a bit so that they can be successful? Do they need to understand what's triggering them? I believe that when students understand what triggers them in the learning process, they can help manage it and then become better learners. I had a student once, and I noticed every time I spoke to him, hey, Mike, he would literally turn white as a sheet, become diaphoretic. Just way off the mark. So I pulled him aside and I said, so can you help me understand what's happening every time I approach you? I don't believe I'm approaching you differently, but tell me what you're seeing when you see me. This kid begins to cry, Dr. Dries. Balls of tears, shaking physically. And so I sat him down and he said, every time I see you, I see my dad. Every time you call my name, I see my dad. And he was an alcoholic and he called me all kind of names. So we had to work through that. And so I had to tell him, so I don't always know. I'm going to try not to trigger you. But when you're getting a certain way, then you need to tell me that you need to step off. What you need to do. Now, you're still accountable for your patient. But if you need to sign off to another student, if you need to step away, we need to work through that until you can gain some more strength. So we have to be honest with students. Everyone's not going to be a med-surg nurse, Dr. Dries, everyone. But we have to tell the student, but you have to learn the concept. Don't be frustrated if you don't like med-surg. It's okay. You're learning the concept to get you to your future so that you build upon their dream. Build upon where they do have gifts and talents so that they can finish this program. And I think students know that this isn't the end all because they don't have to do med surg. They don't have to do ICU. Maybe they're going to be a good community nurse, but we got to just chug through this program so that you keep their hope alive. And I think that is essential to navigating their past traumatic experiences.
It's that visibility and that presence through the story you just shared, having that great situational awareness and noticing, taking the pulse of your students daily and being empathetic, but like you said, still holding them accountable, but focusing on growth, focusing on their strengths, what they're doing right, and being flexible and accommodating. I like to say that faculty are the chief academic retention and engagement specialist, right? You're there to grow them and retain them and engage them, but they, as they put in that work and really creating that culture of community and belonging and safety. So,
well, it's important because we have to, sometimes students do have to pivot, and a pivot doesn't mean you're not going to reach the dream. And I think that sometimes we're afraid to have that conversation. And I don't mean pivot out of the program. I mean pivot in getting help as you complete. I remember having a student in clinical, and I noticed that she could never get into the personal space of the patient. She would be trying to listen to their heart and their lungs with the outstretched hand. And I thought to myself, so it's important in trauma, when we're talking about trauma-informed care, the essential question is, what has happened to you, not what is wrong. So in this instance, I'm like, I know I didn't teach that to her in clinical skills. What is this? That's what I could have been thinking. What is this? I asked her to come see me. And I said, help me understand. I noticed that when you're with your patients, you have a hard time touching them, assessing them, helping them get dressed. She said, Miss Gray, she said, remember when I told you I had a 14-year-old daughter? I said, oh, yeah, how's she doing, She said, oh, well, she wants to know who her father is. I told you she was acting out, and which she had. I said, okay, yeah, you told me that. She says, and she wants to know who her dad is. I said, oh, okay. She says, and I don't know how to tell her that her dad is my father. And that my father molested me from the time I was 5 until I was 14. And I was pregnant with her. And every time I touch a patient, I'm so afraid that I'm going to make them feel like I felt when I was mistouched by my dad. That was heavy, Dr. Dries. I wasn't prepared. But in that instance, I said, what do I do? So I said, we're going to have to get you some help. We're going to need to pivot a little bit. Yep. We're going to make it through this semester, but I'm going to connect you with some help with the Trauma Recovery Center, one of the trauma recovery centers in our area. And you're going to need to work through this, just because you do. And so long story short is she did get the help and she did eventually graduate 3 years later, but she did graduate and was healthy and happy doing it.
What a powerful story, and how nurse educators can, as you're staying calm and positive and listening to these stories and having those crucial conversations and being that conduit to the resources that the student needs. Such a powerful place to be in as a nurse educator. So of course, supporting students starts with supporting ourselves. So I'd like to talk to you a little bit about how faculty can stay grounded while doing this important work. So we know that it can take a toll on nurse educators, just by that story you had shared. What do you wish more faculty understood about their own nervous systems and emotional boundaries, and how can they stay grounded and compassionate without burning out?
Well, I think they first have to really do an assessment of themselves. I think that we have to, as deans, administrators, we have to consider, what culture are we building? What culture are we creating? It's sad to me that there are more and more articles in the literature about the gaslighting that goes on in academia. How can we expect to model for students the caring and behavior that we want them to demonstrate with patients when we're gaslighting each other and creating really toxic culture. So one, we really have to, as leaders, we have to be mindful of the culture that we're creating. We can't be so afraid of not being able to replace a faculty that we don't call bad behavior out. It just isn't fair, especially when the nurse educator pathway is aging out. Our nurse educators are aging out. We're never going to replace them in cultures when the cultures are so negative. So one, that's really key, is we really have to address the culture. And we have to determine how can we make nursing education one that has workplace balance? I have never met an educator that said they could end their day after their shift or after their clinical. But why can't they? Why can't we set boundaries and say, students, your faculty are going to answer emails after 4:00? They'll not be answering. They're not expected to answer all weekend. You don't have permission to just text them and gaslight your faculty on these websites, rate your professor and all that stuff. And we have to spend time in understanding what is happening to that faculty. We have to help understand that our faculty are part of the same context of life that our students are. Before the pandemic, the Center for Disease Control said that over 60% of all Americans had at least one adverse childhood experience. Now, post-pandemic, it's almost everyone has had a traumatic experience. Given the workplace violence that is now going up and we believe is really underreported, all of this has an impact on faculty, on mindset, on culture. So we have to help our faculty, one, again, know that they're human, help them set boundaries in our programs, help our faculty do a self-assessment. Maybe I don't need to teach med-surg this year. Maybe I need to go teach community to kind of have a break. Why do we have to be married to a course for 15 years? I know the challenge that onboarding to a new course can be, but how can we make it easier? How can we aid those transitions so that faculty are building new skills, that they're learning, that they're being seen, that they get a time of refreshment? How do we mentor and invest in people so that they feel room to grow and room to breathe? I think that we have to be intentional. We have to say that because we've always done something a certain way, we don't have to continue to do it. Doesn't mean that it has to continue to be written in stone and to be able to see life differently.
You mentioned new nurse educators who may really want to embrace trauma-informed teaching, but feel the pressure. You got to toughen up those students. Don't be so easy on them from maybe their peers. What advice would you give them to stay true to their values?
We don't need to toughen students up. I think we need to help them understand compassion, understand resilience, and understand the community. I think part of helping students learn, Dr. Dries, is we have to know the communities that we're teaching in. If we're in a disadvantaged community hospital, we need to teach the students, about that community, about the trauma that their patients are experiencing. We have to help the students see the patient and their service through the lens that the hospital, that the patient are going through. Because if we use verbiage about toughening students up, then that's a personal judgment that we are putting on the student, and we can't do that. We shouldn't be judging them and deciding what's tough. What we want to build is resilience. What we want to build is critical thinking. What we want to build in the students is some sense of flexibility and compassion, because you have to navigate clinical nursing in any acute care facility. You're changing staff every 4 hours and you're getting 2 and 3 admissions. That is not about toughness. It's about resilience and flexibility and teamwork. So I think we need to reframe our conversations and hold true to that as a value so that we value the student being successful in life and practice, not just on the NCLEX. I mean, our end game cannot just be that everybody passed it. We do need them to pass the NCLEX, but in that score, there are other things we need to have our eye on and that we need to value if we're going to properly serve our communities and our programs.
So if you could change one thing about how we train and support educators to do this work, what would it be?
I believe that we need to mentor them better. We need to understand that just because a person was a good clinical nurse does not mean that they know how to teach. So we have to give them capacity to do that. They shouldn't have to do a committee. If it's your first year or two, you don't need to do a committee. You need to learn how to teach, right? And then you can have something to contribute to a committee. But first, take that pressure off. So I think mentorship is important. Our younger nurses, our younger faculty are coming in with the same anxiety that our students are not. They're often just 4 or 5 years past where our students might be in age. So they're having that same challenge. So we have to think intergenerationally in our programs. We have to think about mentorship and support and dismiss this thought that because I'm a nurse, I know everything. Nobody knows everything. We all have to ask for help. And I let my students see me ask for help. That's a good question. I think, we're going to find that out together. This is a new product. Let's check on it together. I always have felt that it's a little unfair to expect students and new faculty, Dr. Dries, to do something perfectly that they have never done before. And then if they don't do it well, we want to fail them or fail the student, dismiss the instructor. Because when they go into clinical, they might never do it, or they're going to do it with new equipment that they've never seen before. So it's all going to be new, right? So why do we put this pressure on our faculty and on our students? It's not about perfection. It's about the concept and the thinking around the task, around the teaching that we want to build, so that we build within that instructor critical thinking, the ability to see, the ability to ask questions, the ability to use the resources in our clinical facilities. And that's what I think as educators we can do. We can better partner with our acute care facilities and help them partner for those use of resources to help our new educators so that they go the distance. And we have to create creative ways to I think our pathways for progression. Is there another way? Are there other paths for leadership, for recognition that might not be the associate dean or dean because that's a very limited scope? But what else can we do to develop them?
I've often said that in order to care for students, you have to care for the faculty. And, giving them a proper onboarding and the resources so that they can be successful to best care for those students, right? So as we look at trauma-informed teaching, hopefully becoming the norm, right? Not the exception. What is one spark, one last insight you hope educators carry with them after this conversation? What would that be?
The spark, I believe, is to really look at yourself and be aware of your own triggers. When you look at yourself and where you are in your teaching journey, you have to ask yourself, what has happened? Not what is wrong with me. If I don't have the energy and the excitement about teaching that I used to have, not what is wrong with me, but what's happened. And then what do I need to do? The key is, I think, some level of vulnerability to be able to have a conversation with myself, with my leaders, without judgment, and then to know that there are opportunities for growth, opportunities for wellness, opportunities to set boundaries. So I think my key spark is, number one, know your own triggers. Be able to ask yourself what has happened to me, not what is wrong with me, so that I can go forward to best help my students and help myself.
I think a lot of this work really aligns with an article that I had read about Kolarutis and Pohl, 2021 article. And their work really talked about hearing the students, seeing them, protecting them, preparing them, supporting them, caring for them, and honoring, them, but also doing the same for faculty as well. So Dr. Gray, thank you for reminding us that behind every student is a story, and that empathy isn't just a soft skill, it's a powerful teaching tool. Your insights today are more than just informative. They're really a call to action. And to our listeners, if you're wondering where to begin, as Dr. Gray had said, you start small. How you greet students, how you give feedback, how you care for yourself so that you don't burn out. These are everyday choices that you can make that have and create powerful ripples. So trauma-informed teaching isn't about having all the answers, right? We're not perfect, as Dr. Gray had said. It's about creating space for healing and growth and connection. One classroom, one conversation at a time. So let's keep building learning environments that don't just teach, but truly support. Thank you, Dr. Gray.
Thank you so much, Dr. Dries. I've appreciated this time and sharing with you.
Thank you for joining the Lippincott Spark, Illuminating Nursing Education podcast. Enjoy this episode, subscribe, share, and leave us a 5-star review. For more information, click on the link below to learn more about Lippincott Nursing products and services. Until next time, keep leading, learning, and making a difference in nursing education.